Welcome to our video entitled Two-Stage Endoscopic Mucosal Resection is a safe and effective salvage therapy after a failed single-session approach. Our group of authors is from Westmead Hospital in Sydney and other states in Australia. Wide-field endoscopic mucosal resection has become the primary treatment of large and laterally spreading larger than 20 mm lesions in the colon. As a day case procedure, it has cost and morbidity benefits over surgery, and modelling indicates that it is also safer. When single-session EMR has failed, there may be a benefit to repeating the procedure at an interval, allowing the mucosal defect to heal, highlighting residual adenoma, and allowing either further purchase on the snare or the use of adjunctive techniques to complete the endoscopic mucosal resection. We aim to investigate the safety and efficacy of two-stage EMR, tsEMR, in situations where single-session EMR had failed at a tertiary referral centre. If complete snare excision could not be achieved in a single session at the tertiary centre, the patient was either referred for surgery or a repeat resection attempt, two-stage EMR, was scheduled. This decision was completely at the discretion of the treating endoscopist and took into account the predicted complexity of a further procedure and the wishes of the patient. Two-stage EMR in this study always referred to a second attempt at resection at a tertiary centre. Both groups, both the tsEMR or two-stage EMR group and the single-session EMR group, included lesions which had been previously attempted at other centres, and in the paper we have stratified these out throughout. If the patient was booked for a two-stage EMR, this occurred 1 to 2 months after the initial index procedure. At two-stage EMR, the scar was located and the residual adenoma resected by snare using a standardized endoscopic mucosal resection technique that we describe throughout the study. If there was extensive residual adenoma, injection was performed away from the scarred area in order to commence the resection, and the step created by this resection plane used to allow purchase on any area of non-lifting adenoma. Adjuvant thermal therapy with argon plasma coagulation or snare tip soft coagulation was used to ablate microscopic residual adenoma. The results of this study are as follows. 1,944 laterally spreading lesions of median size 35 mm underwent endoscopic mucosal resection. Of those, 43 laterally spreading lesions underwent two-stage EMR due to failed single-session approach, with success in 36 or 83.7%. Compared to single-session EMR, two-stage endoscopic mucosal resection lesions were larger, a median size 50 mm versus 30 mm, exhibited more submucosal fibrosis, and histology was more often tubular adenoma and less often serrated. Lesions mainly required two-stage endoscopic mucosal resection due to non-lifting or poor endoscopic access to the target lesion. Failure of two-stage endoscopic mucosal resection was predicted by larger lesions. The safety was comparable to a single-session approach, with no episodes of delayed bleeding or delayed perforation after a second-stage approach. Of the 33 laterally spreading lesions that underwent two-stage endoscopic mucosal resection for benign disease and completed first follow-up, 80% avoided surgery to long-term follow-up. The strengths of this study include the involvement of 4 academic tertiary referral centres and the consecutively described lesions over 8 years collected in a prospective fashion. However, the small number of patients means that this study, at best, can only be described as a pilot study. In conclusion, our presented study demonstrates the feasibility of completing an endoscopic mucosal resection procedure at a second session 1 to 2 months after the first. The technique is safe and effective, and while it cannot be recommended as a first-line therapy, it may be useful to endoscopic practitioners when a second procedure is preferred over surgery for reasons either to do with patient choice or to do with practicality or age, etc. Such lesions may be expected to be encountered more frequently in tertiary endoscopic practice as EMR becomes the primary technique for the management of laterally spreading lesions. Part of this discussion should include discussion of lesion complexity and how to stratify lesions by complexity so that they are attempted and completed by the right person in the right place. Compliance with high-quality endoscopic surveillance is mandatory, particularly in these complex patients, since recurrence or recurrent adenoma is commonplace and must be treated at surveillance examinations. We thank you for your attention and for watching the video, and we hope you'll go on to read the paper.